Thank you, Neil, and thank you for the invitation to come and present today. As he said, my name is Tom Metherell. I'm a PhD student here at UCL in Centre for Longitudinal Studies, and I'm going to be presenting today our research about social media use in adolescents and its relationship with psychiatric diagnoses in secondary care in England. Before I start, I do, as a matter of kind of transparency, have the following interest to disclose. I have some shares in social media companies and the technology sector. In all cases, the amounts I'm talking about are much, much less than £10,000. And also my co-author has received some consultancy fees and also has some shares and a patent pending as well. So that's just in the interest of transparency. So let me start by first of all talking about the state of existing evidence in this field. Now, obviously, this is a field that's attracted a lot of attention in the media and in policy spheres, and in particular in the last few days. I'm sure we'll have an interesting discussion about that later. I just wanted to come back a few years to the state as it was when I started my PhD, and this umbrella review came out about the impact of social media use on adolescent mental health, and at that time, the conclusion was that the effects of social media use are small, according to most reviews in the field, and the findings are generally inconsistent across studies. And I think this speaks to a broader problem that we have in this field of social media use of mental health, where the methodologies that we use have a lot of limitations to them, and the data that we have don't really allow us to answer questions in a way that is useful for policymakers or for practitioners as well. Now, one of the problems in this field, and again, this is only one of the problems, I think there are many others as well, is that nearly all studies use self-reported mental health symptoms as the outcome measure. Now, Chia mentioned earlier that she was looking forward to seeing a different and deeper perspective. I'm not sure that I agree that this is a deeper perspective necessarily. I think that when we're talking about the use of mental health services as opposed to the mental health symptoms that are self-reported, these are two different things. And one includes a lot of biases that come from access to healthcare, for example. But it is a different perspective, and it's something that we need to focus on as well, because there is a lot of talk about the increasing demand for mental health services in England and in the other countries around the world. And it's useful to have direct evidence that tells us whether or not this might be related to social media use, and if so, whether there's anything that we might be able to do about it to reduce the increasing demand for mental health services among young people. The problem was that until recently, it was quite difficult to find good data for this. Like maybe you would have access to health records, maybe you would have some kind of self-reported measure of people using mental health services for their mental health difficulties, but you would not necessarily be able to link that to social media use because you wouldn't have those two sources of data in one place. And therefore, it was very difficult to directly find evidence that would show any relationship between social media use and mental health diagnoses and use of mental health services. Now, one possible solution that's become available in the last few years is the availability of data linkages to longitudinal studies. And I'm sure everyone here is interested in this kind of topic. In the last few years, this has become available to a number of studies. Here at UCL, we have obviously the Millennium Cohort study, which focuses on adolescents who were born in, well, they're actually not adolescents anymore, who were born in 2000 to 2002. And in 2022, the linkages to certain NHS health records data became available, and that is increasing across time as well. So the one in particular I'm focusing on here, because this was what was available when I started this project, is the hospital episode statistics, which covers admitted patient care, which is inpatient care, and also outpatient care, as well as also there's an emergencies care data as well. We didn't use that in this particular case. This allows us to directly link the life course survey data that we've collected since these children were born and throughout their lives to health records that have been collected for just general healthcare purposes, and in theory at least reflect the usage of mental health services by these young people. So that allows us to do a more direct investigation of social risk factors and their relationship with healthcare use. So that's why we then set out to model the longitudinal relationship between these two things to see if we could find any evidence to suggest a relationship between social media use and psychiatric diagnoses later on. Now, in order to try and do the best job that we could of taking into account all the other factors that exist in participants' lives as well that may also affect their mental health and also their social media use, we recruited two young people who have lived experience of social media use and psychiatric distress. and we then co-produce a theoretical framework. And I'm doing a preamble here because I'm about to show you a horrific figure. This is the DAG that we co-produced together in a meeting that lasted a very long time, and it includes all the factors that we could identify that could be confounders of this relationship between social media use and mental health, or possible mediators as well. And not just mental health, but also considering that the factor that we're talking about is actually use of mental health services, and that incorporates also factors to do with access to healthcare, health-seeking behavior, and other things that might cause people not to get access to mental health care when they are suffering from mental health symptoms. So there are a lot of things in this diagram, and it's not important to understand everything that's going on here. But there are socioeconomic factors, there are just social factors more generally, etc. There's a lot of things on this graph, and we tried to adjust for as many of these as we could when we did our analysis, at least that are considered to be confounders rather than mediators. I think there were 60 candidates for confounders in total, and we've got roughly half of those that we were able to operationalize in the data set that we have, which is the Millennium Cohort Study, as I mentioned. So yeah, it is worth noting that although we've done the best that we can, there are still a lot of confounders that we think may still be impacting this relationship that we haven't been able to control for. So just be mindful of that as I go through the results as well. In terms of the other variables that we have, first of all, in terms of exposures, we have social media use, which was self-reported in two different ways. We're covering here two different periods of the Millennium Cohort Study between three different sweeps of the study. So starting age 11 through to age 14, and then starting age 14 to age 17. At age 11, frequency of social media use was self-reported by participants in a kind of just, they reported their frequency that they perceived as using social media, sorry. And then at age 14, there was a time use diary that was completed by the participants, and they, in that, reported the number of minutes of social media use that they did across 2 days. And one of those was on a weekday, and one of those was at the weekend. In addition to that, we also wanted to see if we had kind of enough power to even detect anything at all, and also compare this to other exposures that have also been posited as potential causes of mental health distress as well. So in terms of competing exposures, we also tested the relationship between sleep, exercise, and social interaction in person, and psychiatric diagnoses in each case, and we modeled each of those separately. Then we also employed some negative controls just to make sure that to see whether our adjustment of confounders had done a pretty good job. So we took some variables that we thought would have a similar confounding structure to the social media use, but that would not be expected to be causally related to mental health. So we have number of employees at the parent's place of work as a kind of economic factor that we don't expect to be associated with mental health, but could be confounded. And then also attitudes to pirating music as a more social factor that we would expect to be confounded, but again, wouldn't expect to have a causal relationship with mental health. And finally, as a positive control, just to see that if we could detect anything at all, we just tested the relationship between SDQ, total difficulty score, which is obviously a mental health measure, and psychiatric diagnoses. And obviously in that case, we would expect there to be a causal relationship, and we would expect to find an association when adjusting for confounders as well. So moving now to the analysis procedure. Obviously there was a lot of data cleaning and pre-processing. In order to deal with the fact that some participants don't consent to linkage of the health records as well, we had to derive inverse probability weights. So we calculated those using, I've forgotten the word, logistic regression. And then we multiplied those non-consent weights by sampling weights to fully weight our sample to make it representative of the population of England as a whole. Then we performed another round of multiple imputation for our actual analysis, and this was compatible as well with the substantive model that we used, which was a Cox proportional hazards model. And we adopted a survival analysis approach to test whether social media use at the beginning of the period that we're talking about was associated with an increased hazard of mental health service use in the following 3 years. And we operationalized mental health service use in this case as a service use that is associated with a psychiatric diagnosis. Okay, so moving now to our findings. First of all, I'm going to do this by period. So first of all, age 11 to 14. In this period, we didn't find anything at all, essentially, in our main exposure of social media use, or in any of the negative controls or the competing exposures. But our positive control of mental health essentially was associated with psychiatric diagnoses, which was reassuring to see that we could detect something. So we didn't find any evidence here that social media use was associated with an increased hazard. It's important to note here, I think, that at age 11, and especially when this was collected, which was in around 2015, 2014, 2015, the social media use was a lot lower in general population, and the rates of high social media use were pretty low, especially high by today's standards. So that's worth noting. But yeah, there was no association found in this period. In the age 14 to 17 period, again, there's no association that we could find between social media use and psychiatric diagnoses, and negative controls are all also null, which is also good to see. When we look at the competing exposures, exercise and social interaction, it's not significant. Maybe it's that side of the line a little bit, but we can't really say anything about that. But in terms of sleep, we did see that increased sleep was predictive of having a lower hazard of psychiatric diagnosis in the following 3 years, which is probably as we would expect. And then again, a positive control of mental health symptoms was associated with psychiatric diagnoses as well. So yeah, we found it interesting that sleep did actually come out as a factor that was predictive in this case, but social media use didn't. Finally, once we'd done that, we then thought about how we could extend our analysis a bit more, and in many ways we were limited by the power that we had. The linkage rate is a little bit lower than we would like, perhaps, and so there are fewer participants available to conduct this kind of analysis. But we did want to see whether we could detect any evidence of a non-linear relationship between social media use and mental health. So to do that, we categorized social media use at each time period into a series of categories that kind of reflect either no social media use, moderate social media use, or very high social media use. So at age 11, obviously, we're talking about frequency of social media use. So the highest frequency option at that time, and this perhaps speaks to the change in the environment that we have now, is the highest was at most days. And nowadays that would obviously be considered much too low for the highest category. And when we compare it to moderate social media use, neither the group with no social media use nor the group with social media use most days had any difference in the hazard of psychiatric diagnosis, really. However, at age 14, we categorize social media use instead into no use, 0 to 2 hours per day, or more than 2 hours per day. We've actually had to suppress the coefficient for the group that's more than 2 hours, because even at age 14, still the number of people using social media for more than 2 hours per day and who had a psychiatric diagnosis was less than 10, so we had to suppress that because otherwise it would be disclosive. However, what we did find, and this was interesting, was that the group that had no social media use had a much higher hazard of psychiatric diagnosis in the following 3 years than the group that had moderate social media use. So looking at that excluded group, it seems that they actually had a higher hazard of psychiatric diagnosis, which is perhaps not what we would expect, and speaks to concerns that we might have about the policy decisions that have recently been taken, and also factors that might lead to young people not being able to find community online and the impact that might have on them. But this is definitely not causal evidence. This was done post hoc, and we didn't pre-register this specific analysis. So this is not at all conclusive. It is something that we need to bear in mind, and I think needs to be investigated further. Just want to briefly talk about a few limitations. I'd already mentioned a couple of these as I was going through the presentation, but I think it's just worth bearing those in mind again. There is a poor coverage for mental health diagnosis in HES because of the existence of the mental health services dataset, which is designed for that purpose, and many NHS trusts don't actually report mental health diagnosis in HES at all. MHSDS linkage is actually now available to the MCS, but it wasn't when we started this, so I think that will be a useful extension for this project in future, but unfortunately I don't have time to do that right now. As well, we have a kind of aggregated metric of social media use, but it doesn't allow us to consider different types of social media use, different content that people might see on their screens. And those, I think, will be increasingly important to understand as we go forwards, including in longitudinal studies. And I hope that we can make improvements in how we measure the social media use as we develop these studies. Also, these measures are self-reported, which has been shown in numerous studies to be a pretty poor predictor of actual social media use. And so I think the more that we can integrate objective measures of social media use into longitudinal studies, the better. We had limited statistical power, as I mentioned, because of the fact that there were several things that caused people to be excluded, such as like mainly non-consent to being linked to HES. And so again, it will be useful to have other ways of investigating this kind of question as well. This is a non-causal design. we've done our best to approximate a causal design, but there are a number of confounders that we anticipate haven't been measured and haven't been adjusted for. And there are other reasons as well why this shouldn't be considered causal evidence, and there is more work that can be done there as well. And as I mentioned before, there are biases in the access to and seeking of healthcare and diagnosis that will also bias our findings as well. And so I think it's worth doing some investigation into whether we can identify factors that lead to people being excluded from from mental health care to try and understand better how these biases might impact our results. Just to conclude, I would say at this stage that the claims that social media use is responsible for large increases in demand for young people's mental health services aren't evidenced. I don't know of any convincing evidence that that is the case. It's not to say that it isn't the case, but I don't believe that we can show that causally yet. Also, we need to consider the possibility that exclusion from social media may also carry mental health risk, and I think this is a particularly important question with the developments of the last few days. And I hope that future research will continue to develop data collection methodologies and statistical methods so that we can get a more nuanced understanding of these questions and develop some less blunt tools to try and intervene in young people's mental health in the future. That's it for me. I just want to say thank you, and also thank you to my co-authors who are listed here. If you were interested in this work, you can read the preprint of this QR code here, and it's available on site archive as well if you can't scan that right now. If you have any questions, please feel free to ask in the Q&A, and also you can email me, reach out to me on Blue Sky. This is also my website if you have any other interest in my work. Thank you very much. I'll hand back to you.